Good morning everyone. Today we will learn about nerve blocks in oral and maxillofacial surgery. Number 1. Inferior alveolar nerve block. Let's have a look on its introduction. Inferior alveolar nerve is the posterior branch from posterior division of mandibular nerve. Course or relations. It is deep to lateral pterygoid muscle behind lingual nerve. Then it runs in pterygomandibular space, between medial pterygoid and ramus of mandible, then it enters into mandibular canal through mandibular foramen. Before it enters the canal, it supplies mylohyoid and anterior belly of digastric muscle. After entering the canal, it supplies roots of lower jaw and skin of chin. Within the canal, it gives branches to the roots of molars, premolars and canines. Then it divided into two branches. A. Mental nerve supplies skin of chin, comes to surface via mental foramen. B. Incisive nerve supplies roots of incisors and canine teeth. Which are nerves anesthetized? Number 1. Inferior alveolar nerve. Number 2. Incisive nerve. Number 3. Mental nerve. Number 4. Lingual nerve. Now let's have a look on the anatomical landmarks. Number 1 is mucobuccal fold, number 2 is anterior border of ramus of mandible, number 3 is external oblique ridge, number 4 is retromolar triangle, number 5 is internal oblique ridge, number 6 is pterygomandibular ligament, number 7 is buccal sucking pad and last number 8 is pterygomandibular space. You can see the back end of explorer points the mucobuccal fold. The black line shows anterior border of ramus. You can see the tip of the explorer running clearly shows the external oblique ridge. The triangle which you see is retromolar triangle. The line which you see is pterygomandibular raphe. The circle which you see is buccal sucking pad. What is the area of insertion? It is on mucous membrane on the medial side of mandibular ramus, at the intersection of two lines, one horizontal representing the height of needle insertion and other vertical representing the antero-posterior plane of injection. What are the important points to be remembered? First is the target area, so it is at inferior alveolar nerve as it passes down towards the mandibular foramen but before it enters into the foramen. Second is position of patient which should be supine or semi-supine. Third is position of operator which is, for right eye A and B it is 8 o'clock, for left eye A and B it is 10 o'clock. What are the three parameters to be considered? Number 1, height of injection, so it is an imaginary line extends posteriorly from the fingertip in the coronoid notch to deepest part of pterygomandibular raphe determines the height of injection. It should be 6 to 10 mm above the occlusal plane. Number 2, anteroposterior placement of needle A. Point 1 falls along the horizontal line from the coronoid notch to deepest part of pterygomandibular raphe. B. Point 2 falls on a vertical line about 3/4 of the distance from anterior border of ramus. Number 3. Depth of penetration in it, bone should be contacted. Now average depth of penetration to bony contact, in adult, is 20 to 25 mm, 2/3 to 3/4 length of long needle. When bone is contacted, aspirate in two planes and if negative, slowly deposit 1.5 ml of anesthetic over a period of 60 seconds. While withdrawing syringe, when approximately half its length remains within tissues, reaspirate. If negative, deposit 0.2 ml to anesthetize the lingual nerve. What are the signs and symptoms? Subjective signs are tingling and numbness of lower lip which indicates mental nerve anesthetize and tingling and numbness of tongue which indicates lingual nerve anesthetize. And objective signs, absence of pain. What are the complications of inferior alveolar nerve block? First is trismus of medial pterygoid muscle. Second is transient facial paralysis due to deposition of anesthetic into body of parotid gland blocking facial nerve. Third is hematoma.
So here's a live demonstration for inferior alveolar nerve block. As discussed earlier, the operator has palpated all the landmarks and then after analyzing the height of injection, antero-posterior placement of needle and depth of penetration, he has decided the injection point and then he has aspirated in two planes and after it came negative, he slowly deposited 1.5 ml of local anesthesia over period of 60 seconds. Then he withdraw the syringe up to half of the needle and reaspirate. When it came negative, he deposited 0.2 milliliters to anesthetize lingual nerve.
Second one is long buccal nerve block. Starting with the introduction, the buccal nerve is a branch of anterior division of mandibular nerve. Course and relations. The buccal nerve passes downwards, anteriorly and laterally between the two heads of the lateral pterygoid muscle. At about the level of the occlusal plane of the mandibular second and third molars, it divides into several branches that ramify on the buccinator muscle. It then sends fibers to the mucous membrane of the cheek region and other fibers distribute sensory innervation to the skin of cheek. This branch supplies sensory fineness to the buccal gingiva about the mandibular molars and the mucous membrane of the lower part of the buccal vestibule. Let's discuss about the nerves anesthetized. So it is buccal nerve. What are its anatomical landmarks? 1 external oblique ridge, 2 retromolar triangle, 3 mandibular molars, 4 mucobuccal fold. Here the running tip of explorer shows external oblique ridge. The triangle in the video is the retromolar triangle. So the outline shows mandibular first and second molars. The line designates mucobuccal fold. Some important points to be remembered while giving buccal nerve block. First is area of insertion, which is mucous membrane distal and buccal to the most distal tooth in the arch. Then there is target area, which is buccal nerve as it passes over the anterior border of ramus. Next is position of patient should be supine or semi-supine. Then there is position of operator, which is for right buccal nerve block 8 o'clock, for left buccal nerve block 10 o'clock. The depth of penetration is seldom more than 2 to 4 mm and usually only 1 or 2 mm. Aspirate in two planes and if negative, slowly deposit 0.3 ml over 10 seconds. What are the signs and symptoms? Number 1, because of the location and small size of the anesthetized area, the patient rarely experiences any subjective signs. And number 2, objective signs, absence of pain. Lastly, its complications, which include hematoma. It is bluish discoloration and tissue swelling at the injection site. The live demonstration shows the operator directing the syringe and injecting distal and buccal to the second molar to provide anesthesia. Now we will discuss about mental nerve block. Starting with its introduction, the mental nerve is a terminal branch of the inferior alveolar nerve. Course and relation. As the inferior alveolar nerve reaches the region of mental foramen, it divides into two terminal branches. The mental nerve exits the mental foramen at or near the apices of the mandibular premolars, providing sensory innervation to the buccal soft tissues lying anterior to the foramen and the soft tissues of the lower lip and chin on the side of injection. Now, what are the nerves anesthetized by this block? So it is the mental nerve, a terminal branch of the inferior alveolar nerve. Second thing is its anatomical landmarks, which includes mandibular premolars and mucobuccal fold. The circle shows mandibular premolars. The line denotes mucobuccal fold. What is its target area? So it is mental nerve as it exits the mental foramen. The position of patient should be supine or semi-supine. The position of operator is for a right or left-handed administrator in front of patient. Advance the needle slowly until the foramen is reached. The depth of penetration is 5 to 6 mm. Aspirate in two planes. If negative, slowly deposit 0.6 ml over 20 seconds. Its subjective signs are tingling or numbness of the lower lip. And its objective signs are absence of pain. What are its complications? Number 1, hematoma. Number 2 is paresthesia of lip or chin. Here is a live demonstration for mental nerve block. First of all, locate the mental foramen through index finger. It is usually at the apex of second premolar. Then direct the syringe in that area. Slowly deposit anesthesia after aspirating. Last mandibular nerve block which we will discuss is incisive nerve block. Starting with introduction. The incisive nerve is a terminal branch of the inferior alveolar nerve. Its course and relations are originating as a direct continuation of the inferior alveolar nerve at the mental foramen. The incisive nerve travels anteriorly in the incisive canal, providing sensory innervation to those teeth located anterior to mental foramen. What are the nerves anesthetized? So they are mental and incisive nerves. Its anatomical landmarks include mandibular premolars and mucobuccal fold. The circle shows mandibular premolars. The line denotes mucobuccal fold. Important points to be remembered. First, area of insertion, which is at mucobuccal fold at or just anterior to mental foramen. Second is target area, which is the mental nerve as it exits the mental foramen. Third is position of patient, which should be supine or semi-supine. Fourth is position of operator. For a right or left-handed administrator, it should in front of patient. Advance the needle slowly until the foramen is reached. The depth of penetration is 5 to 6 mm. Aspirate in two planes. If negative, slowly deposit 0.6 ml over 20 seconds. During the injection, maintain gentle pressure directly over the injection site to increase the volume of solution entering the mental foramen. This may be accomplished with intraoral or extraoral pressure. Signs and symptoms include number 1, subjective signs, which is tingling or numbness of the lower lip. And number 2, objective signs, which is absence of pain. Complications include number 1, hematoma, number 2, paresthesia of lip, chin. Let us look at the live demonstration of incisive nerve block. The technique is same as mental nerve block. Locate the foramen, then directing syringe, inject anesthesia after aspirating. Just the key difference is we have to apply pressure in incisive nerve block either intraorally or extraorally. Let's learn about maxillary nerve block. Starting with posterior superior alveolar nerve block. Starting with introduction. The posterior superior alveolar nerve is the branch which comes from pterygopalatine fossa of maxillary division of trigeminal nerve. Courses or relations. 2 or 3 branches leave the maxillary division just before it enters the inferior orbital fissure. They pass downward and continue on the posterior surface of the maxilla. An internal branch of the posterior superior alveolar nerve goes along with a branch of the internal maxillary artery through the posterior superior alveolar canal, which opens on the posterior surface of the maxilla. In the bone, the nerve passes down the posterior or posterolateral wall of the maxillary sinus, giving off sensory fiber to the mucous membrane of the sinus. It then supplies the maxillary molars and their gingivae. What are the nerves anesthetized? So it is posterior superior alveolar nerve and its branches. Its anatomical landmarks includes 1. Mucobuccal fold and its concavity. 2. Zygomatic process of maxilla. 3. Infratemporal surface of maxilla. 4. Anterior border and coronoid process of ramus of mandible. 5. Maxillary tuberosity. The line shows mucobuccal fold and its concavity. The marking shows maxillary tuberosity. Points to be remembered. Its areas anesthetized, which includes first, pulp of maxillary first, except mesiobuccal root, second and third molars. Second, buccal periodontium and bone overlying these teeth. Its target area is PSA nerve posterior, superior and medial to the posterior border of maxilla. What is its area of insertion? So it is the height of mucobuccal fold above maxillary second molar. The position of patient should be supine or semi-supine. The position of operator, for left PSA nerve block 10 o'clock. For right PSA nerve block 8 o'clock. Parameters include advance the needle slowly in an upward, inward, and backward direction in one movement, not 3. 1 is upward, superiorly at a 45-degree angle to the occlusal plane. 2 is inward, medially toward the midline at a 45-degree angle to the occlusal plane. 3 is backward, posteriorly at a 45-degree angle to the long axis of the second molar. In an adult of normal size, penetration to a depth of 16 mm places the needle tip in the immediate vicinity of the foramina through which the PSA nerves enter the posterior surface of the maxilla. Aspirate in two planes. If negative, slowly deposit 0.9 to 1.8 ml of anesthetic solution over period of 30 to 60 seconds. What are its signs and symptoms? So subjective signs are none. And objective sign is absence of pain. What are its complications? 1 hematoma commonly produced by insertion of needle too far posteriorly into pterygoid plexus of veins. 2 mandibular anesthesia. Mandibular division of trigeminal is lateral to PSA nerve, so there is chances of deposition of anesthesia. The live demonstration of posterior superior alveolar nerve block. Here the operator goes upward, backward and inward above the height of mucobuccal fold above maxillary second molar and inject the anesthesia to anesthetize the posterior superior alveolar nerve. Second nerve block is anterior superior alveolar nerve block, also called as infraorbital nerve block. Starting with introduction, the anterior superior alveolar nerve is a branch given in infraorbital groove and canal of maxillary division of trigeminal nerve. Course and relations. The anterior superior alveolar nerve descends from the infraorbital nerve just inside the infraorbital foramen in the anterior part of the infraorbital canal. They also send connecting fibers to the superior dental plexus of nerves within the maxilla. Fibers of the anterior superior alveolar nerves also supply sensory innervation to the mucous membrane of the anterior part of the maxillary sinus as well as the labial gingivae of the incisors and cuspid teeth. Nerves anesthetized includes 1. Anterior superior alveolar nerve. 2. Middle superior alveolar nerve. 3. Infraorbital nerve. Inferior palpebral, lateral nasal, superior labial. Its anatomical landmarks are 1. Infraorbital ridge. 2. Infraorbital depression. 3. Supraorbital notch. 4. Infraorbital notch. 5. Anterior teeth. 6. Pupil of eye. Here comes the infraorbital ridge. Here comes the infraorbital depression. The notch which you see is supraorbital notch. The notch which you see is infraorbital notch. The arrow shows the anterior teeth. The red dot shows the pupil of eye. Points to be remembered. What are the areas anesthetized? 1. Pulps of maxillary central incisor through the canine on the injected side. 2. Buccal periodontium and bone of these same teeth. 3. Lower eyelid, lateral aspect of nose, upper lip. The area of insertion is at height of mucobuccal fold directly over the first premolar. The target area is infraorbital foramen. The position of patient is supine or semi-supine. The position of operator is, for a right, left-handed infraorbital nerve block 10 o'clock. The general depth of needle penetration is 16 mm. Aspirate in two planes and if negative slowly deposit 0.9 to 1.2 ml over 30 to 40 seconds. Signs and symptoms: subjective, tingling and numbness of lower eyelid, side of nose and upper lip. Numbness in the teeth and soft tissues along the distribution of SA and MSA nerves. Objective, absence of pain. Complications are hematoma across lower eyelid and tissue between it and infraorbital foramen. This video shows us the live demonstration of infraorbital nerve block. The operator located the infraorbital ridge and notch and then through height of mucobuccal fold over first premolar, injects the syringe and deposit anesthesia. Next is Nasopalatine nerve block. Introduction starting with course and relations. The nasopalatine nerve originates from the PT erigopalatine ganglion, enters the nasal cavity through the sphenopalatine foramen, travels anteriorly and inferiorly along the nasal septum, passes through the incisive canal, and exits onto the anterior hard palate to provide sensation to the gum and mucosa of the incisor teeth. Nerves anesthetized are nasopalatine nerves bilaterally. Its anatomical landmarks includes 1. Central incisors. 2. Incisive papilla in the midline of palate. Areas anesthetized are anterior portion of hard palate bilaterally from first premolar to first premolar. Area of insertion is palatal mucosa just lateral to the incisive papilla. The arrow shows central incisors. The circle shows incisive papilla. Points to be remembered. Its target area is incisive foramen beneath the incisive papilla. The position of patient should be supine or semi-supine. The position of operator for left, right-handed nasopalatine nerve block 9 or 10 o'clock. The depth of penetration is 5 mm. Aspirate in two planes. If negative, slowly deposit 0.45 ml over period of 15 to 30 seconds. Signs and symptoms: subjective, numbness in the anterior portion of palate. Objective, absence of pain. Complications: 1. Necrosis of soft tissues. 2. Hematoma. The demonstration shows the syringe going laterally towards incisive papilla to deposit anesthesia. Last is greater palatine nerve block. Starting with introduction. The greater palatine nerve is the palatine branch from pterygopalatine nerves from maxillary division of trigeminal nerve. Course and relations. The nerve emerges on the hard palate by passing through the greater palatine foramen and course in anterior direction between the osseous hard palate and the mucoperiosteum to supply major part of the hard palate and palatine gingivae. Nerves anesthetized. Greater palatine nerve. Its anatomical landmarks are: number 1, second and third maxillary molars. 2, palatal gingival margin of second and third maxillary molars. 3, midline of palate. 4, a line approximately 1 cm from the palatal gingival margin towards midline of palate. The areas anesthetized are the posterior portion of the hard palate and its overlying soft tissues anteriorly as far as the first premolar and medially to the midline. The arrow shows maxillary molars. Here comes the palatal gingival margin of molars. Midline of palate is seen. A line approximately 1 cm from palatal gingival margin to midline of palate. The area of insertion is soft tissue slightly anterior to the greater palatine foramen. The target area is greater, anterior, palatine nerve as it passes anteriorly between soft tissues and bone of the hard palate. The position of patient should be supine or semi-supine. The position of operator is: for right GPN block 7 or 8 o'clock. For left GPN block 11 o'clock. Direct the syringe from the opposite side. The depth of penetration is about 5 mm. Aspirate in two planes. If negative, slowly deposit 0.45 ml to 0.6 ml over period of 30 seconds. Signs and symptoms: subjective, numbness in the posterior portion of the palate. Objective, absence of pain. Complications: number 1, ischemia and necrosis of soft tissues. Number 2, hematoma. Demonstration shows that the operator first located the greater palatine foramen usually near second molar and then direct the syringe from opposite side and injected the anesthesia. Thank you for watching.